Good afternoon, everyone. I welcome you all to the 114th session of eNishchit. It's our national initiative to strengthen collaboration between HIV TV through a platform of e-learning, and we welcome you all in our endeavor. So today we have ART centers joining from Andhra Pradesh, Arunachal Pradesh, Assam, Delhi, Manipur, Meghalaya, Mizoram, Tamil Nadu, UP, and West Sikkim and West Bengal. Welcome you all. And I'm Dr. Ananya Prabhu, chest specialist at NITRD New Delhi. And with me is on my panel, on my team, Dr. Jyoti from Share India. So and with this, we'll begin the session. And today is going to be a very interesting session. And before I start the session, I have the privilege to introduce our expert today. That's Dr. Amit Sharma. He's a senior chest specialist in NITRD, and he has over 15 years of experience in tuberculosis and other respiratory diseases. And indeed, both a privilege and pleasure that we have him on our panel today because with his vast experience and knowledge and his clinical acumen is really very, very highly talked about in our institute. So we are really very thankful, sir, for you to join us. And I would appreciate that if all of you can ask questions from him because it will indeed a great opportunity to have such a great TB expert with us on the panel. So that's our expert. And today the case will be presented by Dr. Manju Sharma, who is a medical officer, ART Center, Deen Dayal Upadhyay Hospital, Delhi. So thank you, Dr. Manju Sharma.
Good afternoon, everyone. I'm Dr. Manju from ART-C DDU Hospital. There was a patient, 18-year-old patient, female. Weight at the time of her when she enrolled with us was 46 kg. The reason why I was interested in bringing out this case was because this patient had full 1 year course of ATT, but her following the completion of the treatment, her lymph node, she was a case of tubercular lymphadenitis, but her lymph node continued to enlarge even in spite of taking 12 months of tuberculosis treatment. So patient was diagnosed with case of tubercular lymphadenitis and put on ATT category 1 on 15th April 2023. She was also tested positive for HIV during the investigation. Then she came for PRT registration on 12th May with 23 with positive report. She had a swelling in the neck and axillary region bilateral at that time, along with fever and off and on. But when she came to us, she was afebrile because she was already on ATT when she enrolled with us. She also gave history of loss of appetite. On examination, she was afebrile at that time. Her vitals were normal, but lymph nodes were enlarged, batted of various sizes, around between 2 to 5 centimeter in multiple groups in neck and axillary region. She was investigated as per ART protocol, including routine investigations and other investigation to rule out OIs. And she was then started on ARV because she already had ATT for around 1 month when she came to us. So she was put on TLD and DTG on 30th May 2023 and along with CPT, and she was asked to adhere to the treatment. Good adherence counseling was given to her, and she was asked that she should take an extra, she was told about the extra DTG to be taken along with the normal TLD that she has to take lifelong. She improved symptomatically, clinically. Her viral load after 6 months of ART and ATT treatment was within normal limit. Most of her lymph node had gradually resolved with treatment, except for the one in the right anterior chest wall near axillary region, which persisted after 9 months of continuous ATT and ARV. It was around 3 to 4 centimeter size, mobile in one plane, and tender on palpation. She was given 7 days course of antibiotics along with the ATT and ARV, and was advised, but her swelling persisted. Then we advised fine needle aspiration cytology on 13th of April 2024 for the enlarged lymph nodes. She was also referred to surgery. HPR suggested as the histopath report that came out was suggestive of suppurative lesion. patient was referred to surgery OPD for expert opinion, and since she had taken treatment already completed 12 months of ATT, so we withheld her ATT for some time, as her report was also within the normal. There was no, it was not suggestive of tuberculous lesion. At the time of completion of ATT, her weight was 50 kg. There was gain in weight, and she was 4S negative also. And otherwise, a large. Meanwhile, while she was under this process of investigation, the enlarged lymph node that was gradually increasing in size got ruptured spontaneously. We got the CB0 testing also done from the discharge of the ruptured lymph node on date 8th May 24, which reported negative for tubercular bacilli. So at present, patient is on continuous observation and she is coming for regular ART. But what I wanted to know, what was the reason behind the gradual, this persistent enlargement and persistent of probably cold abscess formation or some abscess formation in the lymph node in spite of completion of 1 year of ATT, and do we need to do anything else besides this? Thank you.
Okay. Thank you. Thank you, Dr. Manju. So it has been very well worked up case. The only thing my concern is, was any baseline CBNAT done for the case? CBNAT baseline, any?
Actually, she came to us after 1 month of starting of ATT. She was given ATT from outside.
Acha, okay.
And she was already on ATT.
Okay, because in your report you have written one RIF sensitive, so CBNAT was negative, I believe. So maybe lower down the case you have written RIF sensitive. So I was wondering which report it is.
That was afterwards, after 1 year of treatment, when her lymph node got ruptured on its own.
Okay, because उसमें CBNAT negative आया था, इसमें RIF sensitive लिखा, so I was wondering whether that was a baseline CBNAT or not. Maybe there's some confusion there. It's okay, but it's very well.
This was actually the report she had when she came to us on 14th April 23. That time also FNAC axillary lymph node was done before she came. We did not do it, but she had this report of suggesting AFB stain positive with necrotizing granulomas. Okay. CBNAT was not done at that time.
CBNAT was not done. Okay. So she was rightly put on the ATT and the dose was also increased. And clinically also she responded. So the main bone of concern here is that why the nodes were still increasing. That's what you want to know. And yes, how does it naturally happen in the clinical course or not?
Was there anything else that needed to be done, or should we keep something under observation right now also? Though she is perfectly fine now after the thing got settled.
Yes.
When it ruptured.
Okay, and throughout the treatment, were any repeat CD4, because 6 months any CD4 was repeated?
Yes. CD4 and viral load were within normal limits. I have written.
Because we have one CD4 value, so I just wanted to know whether the CD4 increased in numbers. Was any repeat CD4 done as well?
That's not in the record.
Okay, no worries.
For that. Because at sometimes, in the this investigation was not available in the hospital for some time during her course of treatment, so we could not do that. But we did her viral load after 6 months. That was within normal.
Okay, I understand that. Thank you so much. I think we can move on to the diabetic now. So I now invite Dr. Amit Sharma, sir, to present us diabetic to us.
Good afternoon to everyone. First of all, I would like to thank my colleague, Dr. Ananya. She gave such a detailed description. I am really honored. And thanks to you for inviting me on this precious occasion of giving whatever knowledge I have and also absorbing on this didactic portion of the ECO. And I also thank the ECO team, Dr. Jyoti and Mr. Rakesh. Now, this topic is a very, very relevant topic, because when we are dealing with patients who are having lymphadenopathy, especially cervical lymphadenopathy, the patients are always not very satisfied, because complete regression of the lymph nodes may not be achieved within the recommended duration of treatment. So this is a very relevant topic, and Now I will begin my slideshow. So first of all, this is something that we have to understand, that HIV positive patients, we know that they are extrapulmonary TB, and extrapulmonary TB, more common is lymphadenopathy. So in India, the most common cause of lymphadenopathy in HIV positive patients is Mycobacterium tuberculosis. There may be other bacteria also similar, but we'll not go into that right now. But tuberculous lymphadenitis, it occurs in as many as 60% of patients who have co-infection with HIV and tuberculosis. So you can see the amount of patients who are having this HIV and TB co-infection with lymph nodes. The diagnosis is usually made by an FNAC. FNAC gives you the histopathological background. And since we are now moving on towards the universal DST methods, if available, as per the resources, we should also try to get a CBMAT to detect the rifampicin resistance or sensitive. First of all, we have to be sure, because there may be other causes of lymphadenopathy in tuberculosis patients. The infection itself can cause lymphadenopathy, and it increases the risk of certain conditions in which lymphadenopathy may be there, such as lymphoma. So that differential has to be kept in mind. Now, here is the patient. You can see the patient is having lymphadenopathy in 3 places, and those have been outlined. Now the patient will seek medical attention, this patient, an HIV patient, and when the treatment is began, that is easy. When the treatment should be stopped, that is the most important thing. Because after a certain time, we have to see whether the benefit of treatment is more or the risk of side effects is more. Because antitubercular drugs can have a plethora of side effects, many serious and sometimes fatal. So the studies and the trials are very clear. Randomized controlled trials from all over the world. A lot of trials I went through from other countries also, and they have demonstrated that 6 months of chemotherapy is sufficient for the treatment of most drug-susceptible lymph node TB. However, in spite of these guidelines, observational studies from several countries have reported longer treatment durations in a significant proportion of these patients. And this is not only for those countries. Our country, and truly speaking, even I have done it. But how much of it is justified, that we have to see. Now, it has been observed that patients with HIV infection, HIV infection patients are usually given a longer duration of treatment. This is one of the risk factors of prolongation of the treatment. And has been observed to be the most common factor, which is associated with increased duration of ATT in these patients. Now, as I mentioned, why this is given. Prolonged lymph node TB treatment may derive from fear and misconceptions about treatment requirements. And morbid as it sounds, even if I am having this problem and I know that 6 months of treatment is enough, even I would be aesthetically and that way very apprehensive that it should resolve. So it's a very common scenario that we observe in our HIV positive along with infection of TB with LAP patients. So I'll just go through the studies. Now, here the main thing I would like to highlight, that studies have shown that post-treatment persistence of lymph node lesions, certain studies have shown that around 10%, it can be higher, a little lower, but mostly this much is present. Exacerbation of lymph nodes, even under appropriate medication. Now, this is a very important. Once the treatment is started, the patient should say, I should improve. Well, I would have said that if I was a patient. But because of the body's immune system, which also gets reconstructed by the ART treatment, the body shows a response, which is known as iris. Iris is a kind of paradoxical response. The body, which was initially silent, now, because of the increase in its immune arsenal, reacts against the tubercular infection and causes this paradoxical reaction. In a study, now you can see here that the study was very well done, though it had 24 patients, and out of 24, it was seen that 22 were due to paradoxical reasons and spontaneously resolved on their own. So only 2 patients. So you can see the little thing where you need to prolong the treatment or change the treatment, which I will be dealing. So now you see, if this kind of thing happens after starting of treatment, patient will get very disturbed, worried. But first thing is reassurance. Reassurance. Listen, this is not the infection which is increasing. It is your body's immune strength which is increasing. And such paradoxical reactions are usually self-limiting. The patient has to be counseled that under no conditions he should stop the treatment. And sometimes he may be using steroids because of their anti-inflammatory action with good results. So, as I mentioned, the persistence of TB lymphadenopathy after completion of ATP mostly is due to paradoxical reaction. There may be a small minority, I will say a small number of cases where you have to differentiate whether the patient has actually paradoxical reaction or the patient is actually having some other problem. And this is where the clinical thing, as ma'am mentioned, that though the patient had lymph nodes, she did not have systemic symptoms. Initially, she had. When the infection is present, fever will be present, and lymph node enlargement, if it is due to some other cause. Maybe the rifampicin resistance wasn't done due to technical reasons. It might have been a case of drug-resistant tuberculosis, or it could have been a microbiological relapse. So this patient, you can see that she's having a necrotizing granulomatous inflammation. She continued to be observed on histopathology. Histopathology is not the deciding factor for terminating treatment. The histopathological pattern will persist for a long duration of time, and so would the dead bacilli. So that should not be the criteria. You keep on doing FMAC every time you will get a suppurated lesion. That should not be accepted as a corollary that the patient is having the persisting disease. In this case, the treatment was stopped in the end of 9 months despite recurrent complaints, and steroids were given to this patient, and you can see that there is a almost complete, of course, a scar may be there at times because any healing takes place with scar, but you can see the difference. So this is what I really want to highlight over here. It's the patient's fear which has to be addressed. This is another study where you can see that 92%, almost 92% had a spontaneous paradoxical reaction. However, in 3 cases, retreatment was required. Although, now I had told, as I had mentioned, that relapses have to be also proven microbiological. Now, CBNAT, as Dr. Ananya was mentioning, CBNAT is not a very good follow-up test because it shows DNA. DNA is also present in the dead bacilli. So, Microbiological relapse has to be ruled out by a culture test where you can grow the microbacteria. If they are still present, they will grow. That is one of the conditions. However, you may find a marginal number of patients who may be having systemic features, and you will feel, even after a negative culture report, you will still feel as a clinical that this patient needs to be given a retreat. And usually in these cases, the outcome is good. So their conclusion was post-treatment lymph node enlargement should be monitored carefully. Now that is what even Dr. Manju was mentioning, that should we be monitoring or should we be prolonging the treatment and all these relevant points. So in patients with this type of paradoxical response, retreatment may not be warranted, especially now this is a very important point, good compliance to it. The patient has been taking the medicines or not. Of course, that is one of the cardinal points of ATP. Microbiological, as I said, can be ruled out on the basis of a sterile. This is again the same thing, that further observation with anti-TB therapy, it has been found that persistent lymph nodes resolve. Now, here we come to a excision biopsy. Now, this case was of an 18-year-old lady, 18-year-old girl, I would rather say. So, for a young girl to have a lymph node is very not acceptable from the aesthetic point of view. And maybe if I was in that case, I would feel the same. So, in that case, an excision biopsy can be used to surgically remove the lymph so that that is not visible. I think I have a picture also of that. Yes, so this was one patient in which the lymph node was removed, even though active disease had been ruled out. So there's a minor scar, but that can be hidden by. So there has been observed no statistically significant difference. Now, this is something really has we have to really understand here, that from 9 months to 30 months, no difference. And in fact, large series and clinical trials have shown that only 6 months of chemotherapy may be adequate for treatment in drug-resistant lymph node, drug-susceptible treatment lymph node TB, whether they are HIV infected or not. So there is no difference in the improvement, or rather you would say control of the disease, whether it is HIV negative or HIV positive. So with no additional gain to be expected from the longer duration of treatment. So why should we avoid prolongation of treatment? First of all, that increases the cost of treatment through the drug costs. Now that is something the system may bear, but the patient has to come up for follow-up visits. These patients may be from a comparatively marginalized part of our society, and they may be having a daily wage or those kind of things. So it's a lot of strain on their resources. So that is also something that really affects. Now it also, I'm sorry, my throat is a little dry, so please excuse me, increases the risk. Now, when you are giving drugs, and especially ATT drugs, of course, there will be side effects. And side effects, now this study was there, that 0.49. It means if you extend the treatment by months, this much risk will increase. A study gave this. However, this is a too, I would say, statistical thing. I am simply saying here that prolongation of treatment will increase the risk of side effects of the ATT drugs, all of which may have mild, moderate, severe, and sometimes fatal adverse effects. And of course, adherence. Till when time, even when you put yourself in that situation, every day you have to take a medicine, every day you have to take a medicine. Now, that really affects the patient. It affects the patient psychologically also. That till what extent I can take treatment. I'm tired of taking treatment. So now that will affect the compliance, the adherence to treatment. And this is inversely correlated with the treatment duration. The less compliant the patient is with the treatment, the more the treatment duration may be prolonged. So, but there is always an exception. But exceptions are not rules. Prolonged treatment could be justified in some of the patients who underwent changes in the drug. Now, that is a very important point because when these drugs are started, there may be side effects. One of the most common side effects may be involvement of the liver. When you re-challenge, most of the patients tolerate. But there will be a proportion of patients who will be persistently having severe side effects with one drug, which has to be changed. Now, if that drug is, suppose, rifampicin, which is one of the key drugs, or pyrazinamide also, even if we remove pyrazinamide from a regimen, the regimen is prolonged to 9 months in general. So, any drug which is being replaced or any change in the normal treatment regimen can justify the prolongation of treatment. And of course, as I mentioned, documented drug resistance to one or more drugs in the regime. Of course, because then we will go to a longer resistant TB regimen, which is generally quite longer as compared to the normal. So in these circumstances, these few circumstances, and you won't find these circumstances very commonly if you go by this. So in these circumstances, the prolongation is justified. But again, as I say, exception is there, but it should not be taken as a rule. Now, this is one patient. He was complaining, as you can see over here, there are multiple involvements, and FNAC is being done, pus is being drained, and when it was subjected to CBNAT in this patient, CBNAT, it was found to have RIF resistance. RIF resistance is seen in CBNAT, and it is a proxy for MDR. So in this patient, you will have to take a course of MDR tuberculosis. So it's quite justified in this patient. Quite justified in this patient. True relapse, as I mentioned, in tubercular lymphadenopathy is very uncommon, and hence a lot of caution, circumspection is required before restarting such a patient on ATT. Repeat ATT may expose the patient on the toxic side effect of the drugs. Hence, the risk of ATT may far outweigh, as I mentioned, I'm emphasizing this point, because this is something we face so much in our clinical practice. The patient comes to us, why the lymph node is still there? Why? In fact, in this case, which Dr. Manju presented, they had to stop the ATT and then the lymph node ruptured after. Yet the patient is perfectly all right. That itself speaks. So with this, I will say that in cases of persistent lymphadenopathy, 6 to 9 months, not adding them, I'm sorry. 6 would be the ideal at times, depending on the clinician. The guideline will not say 9 months, but depending on the clinicians, you can prolong it maximum to a period of 9 months. And after that, you have to be very careful whether I should go or whether I should stop. How much the patient will be given. Even in this patient, 1 year was given and lymph node was still there. So a decision was taken to stop the treatment, which was very, I think, very right decision in this case. So it's the counseling, and counseling of such patients is very difficult. Even I would not be so easily counseled if I had a mood like this. So I think that is where we really need to make an effort, and not only the doctors or the clinicians, even the healthcare staff needs to be trained on these things. They should also be able to, because they are the main interface where the patient is interacting with the health system. So they should also be aware. That is where the training of the peripheral visitors and the health staff, who are the hub and the key, of ATT control, of NT, they have to be followed. So with that, I come to the end of my brief didactic. I don't think it was very good, but still I have tried my best. And as per my knowledge, and I will want to address questions from the audience. There must be a lot.
Thank you, sir. Thank you for making things so crystal clear to us. And especially the salient features when we actually practice and what guidelines give this, what we practice, the reassurance and counseling of patients, it plays a very, very major role as the therapy does. So I understand your didactic also has made that amply clear to us. So I would invite questions from the audience. And also Dr. Manju, if you want to ask questions from.
Yeah, I have one question in my mind. Actually, Dr. Saab, you said it could be because of the paradoxical immune response that would have resulted in and probably due to IRIS.
Yes, yes.
But IRIS, Dr. Saab, is maximum up to 6 months, even, we observe in cases of HIV that is noticeable. And in this patient, treatment was started almost a month of anti-tubercular treatment.
I totally agree with you. I totally agree with you, madam.
Possibility of IRIS was a little less.
See, IRIS is not only when the body builds up the CD cells. In that situation, IRIS. Otherwise, in a patient of tuberculosis also, this also happens in other cases like pleural effusion. And usually the paradoxical reaction, as you mentioned, does occur in the beginning or in between. But it is not, I mentioned in the slide that it is 10% of the patients who may have this problem. But all the studies, and even after our experience, we have seen, even after you stop the treatment, after 2 months, the lymph node ruptured and the patient is all right.
Yes.
So this is what I want. See, you are also very right in asking that. Even I think that why should paradoxical reaction take place so long? It's not like that. The body can react anytime, and this has been seen. See, that's why I demonstrated so many studies. So that should convince all of us that it can happen anytime, and that is the most common possibility we have to think. Of course, we have to carefully, which you did, I think, in this case, that you monitor the patient. You say the patient, no, you come to me at these intervals, and I will see. And if you feel the patient is having fever and all those things, of course, go for a lymph node, you can go for a CT. But simply doing an FNAC and having a histopathological picture does not justify prolongation.
Honey, we did. Actually, Doctor, the only reason CBNAT was done after her completion of treatment was that at least TB, if it is negative, then tuberculosis is ruled out. If it is positive, then it is indefinite, because dead bacilli it comes positive in cases of dead also, mycobacteria. But if it is negative, then at least TB is cured.
Yes,
so that will ensure us.
Yes, ma'am. But you, of course, you did everything in the good of the patient with a very good will, intent, and the microbiological relapse should be always. What is the gold standard for diagnosis of tuberculosis? Culture. The bacilli should grow. They should be alive. But that may not occur in many cases. But still, you did your best. You tried to rule out active disease in this patient. And after that decision, you see that it came out very well. So I agree.
Thank you so much, Doctor. It's been very informative, and you cleared almost all my doubts.
Oh, thank you so much for that.
It was a very enlightening session.
Thank you.
Was this chest X-ray ever done, ma'am, Dr. Manju, for this patient?
In the beginning, yes, in the beginning. When she enrolled with us, then it was done as a part of routine investigation.
So chest X-ray has always been a normal?
Yes, sir. Yes, it was normal.
because I'm sorry, I'm interrupting you. Because in many cases, the lymphadenopathy is actually inside. But that is not that problematic to the patient, isn't it? Because they can't see it and we see it on the X-rays, but we say, no, no, it has improved, it has improved. It is when the lymph nodes are outside, when the patient is.
Yes.
But of course, a chest X-ray should always, as Dr. Ananya said,
Yes.
it
Yes,
should
ma'am. It
always.
was done. It was done. It was done.
Of course.
The only positive point in her case was that she was otherwise asymptomatic and forest negative, and rest of her things were also within the normal limit. Had there been some relapse or anything, so,
True. Very true.
so that would have resulted in decrease in CD4 or raised viral load count or anything else.
Of
Maybe it got secondary infected, this notes.
That is also a
Another
possibility.
different- Because that's the area where sweat comes and.
Dr.
Yes.
Dr. Ananya has raised a very relevant point because you can have skin, the lymph nodes may also be infected by acute processes. Acute bacterial infections can occur, certain other infections which may respond to antibiotics. So even we do that in our practice. But if there is a sudden and painful, usually tubercular enlargement is not very painful. So if there is a sudden, unexpected, painful, tender and very that kind, then a course of antibiotic is recommended, especially antibiotics which may act on the staph and all those. That's a different thing. But of course, that secondary infections in these lymph nodes can occur. This is what I also usually do. If the patient comes and there is some kind of thing, I also give the patient a short course of antibiotics, and the patient, most cases, responds very
So I think CBNAT testing was done, so the only thing that could have been was a culture of that.
True.
When you send the abscess, you could have sent the culture, because like we were discussing that is there anything that we missed out. So because as sir said, the tubercular abscesses are usually cold abscesses. They don't behave like this hot abscesses. So that bacterial infection had to be ruled out.
That ma'am, I really agree. I have did that thing. I didn't get the culture done.
Yes.
No, it's not fault finding. It's something that we are learning from you.
But
And
there are limitation also in the sector.
I understand. I understand.
That is the
I understand.
So, if I may please ask a question, I'm unable to find the hand raise option.
Yeah.
This is Dr. Mukut, WHO consultant for the NTP program. So, sir, thank you for the discussion, and as well as thank you to Dr. Sharma as well for the presentation.
Thank
for
you.
the case.
Thank you,
So,
sir.
sir, I was a little bit intrigued to understand the total duration of the course which we can provide in such a case, because you had been very categorical in mentioning 9 months is what is suitable, if I'm not mistaken, and provided if there is a justification to prolong the medication. But, sir, what would be your stand in this particular case? Sorry about that.
That's a very no. So see, these are the things that you have to ask because you have to face the patients. As a clinician, you have to face the patients. See, the studies have shown that 6 months of treatment, that is the major consensus, is only for 6 months, even for HIV positive as well as HIV negative. But 6 to 9 months is something that we do try in patients where the blood supply may be poor, and it's a very subjective thing. If you go for guidelines, it is 6 months. But you have asked me a question, would I? Well, I would. 9 months I would, but not beyond that. Beyond that, I will be circumspect.
Thank you, sir, for the answer. Yeah, please.
Thank you.
I think we can go ahead with the post-test question. We can discuss the test, the questions we have asked and discuss it.
So the first question was, the most common reason for the persistence of or enlargement of the tubercular lymph node after completing the anti-tubercular treatment is option B, immunological response.
This is another word I did mention. It is the same as a paradoxical response. It's part of the immune reconstruction.
So another question was, how much duration of anti-tubercular treatment has been found to be sufficient for the treatment of lymph node TB in HIV-infected patients? So the correct answer is option D, 6 months, as per the guidelines, and rest is depending on the decision of the clinicians.
Just to summarize, if we look at the TB lymphadenopathy case in HIV, there are plethora of things that we have to look at. So once a patient comes and he's on the treatment, and we are partially happy and partially not happy, as in most of the case with the response. We are very lucky if the lymph node regresses and everything is like falling in the place. But if the lymph node does not regress, then we have a couple of things on our mind. We think of whether our ATT is failing, whether our HIV is failing, whether there's a paradoxical response, or whether there's some secondary infection that is happening. And sometimes it's just simple, especially in our HIV cases, that maybe the patient is taking ATT, but we have to check the compliance, and there's so many malabsorption problems that the drug is not having the right effect in the body. So because of they are not eating therapeutic effects because of I just said just because there's so much malabsorption generally, and in HIV it is increased to 2-3 folds. So there are these 4-5 factors we have to look at, and it has to be very, very individually based. We cannot have blanket guidelines that why it's happening. Every case is different, and these 4-5 reasons we have to move around them and find our answers. So I would like my expert to just summarize and give us a take-home point, sir.
So thank you, Dr. Saab. You have given me this opportunity, and I really appreciate the responses. And even I want to learn so much from you. And in the end, I will just say that no, it's not easy, as Dr. Saab said. If everything goes, it goes. But the standard of treatment should be 6 months of ATT, if necessary, prolonged to 9 months on a clinical basis. And if then still, then go for an FNAC, and definitely also the clinical history. Patient is having fever, constitutional symptoms. That is very important. Go for a FNAC and put the samples for culture. But this is not a hard and fast rule. You will still have the feeling that the patient is having the infection if the patient is symptomatic. He or she is having a loss of weight, fever, anorexia. In those cases, a retreatment may be very much useful, as I mentioned in the slides. So with that would be my final summary.
Yes. Thank you so much, sir. Thank you for joining us.
So I thank our expert today, Dr. Hamid, for a wonderful session and giving us the so much of information to resolve the queries. And I thank Dr. Manju, who has bring that case for the discussion. I thank Dr. Ananya for moderating the session so beautifully. I thank my team member, Mr. Rakeshji, for looking after all the logistics and the eco team behind the curtain working. And I thank all our participants who made the show successful. Thank you, everyone.
Thank you.
Thank you so much. Thank you, sir.
Thank you.